Awesome. All right, so yeah, we're right at 45, so we're gonna get started. Thanks so much for coming today, wherever you're coming from. It's early Sunday morning for me, which is not my favorite time in the world. So I'm happy to be here, but also not very happy. So yeah, this is the presentation that Claire came up with, all amazing title called Standardized Language and Non-Standardized Identities, Gender Diversity Data Collection in Healthcare. And we have full presentations today from all my wonderful panelists. We're going to start with Claire, and then we're going to go over to Zach and Laurel. I'm going to leave it up to them to introduce their talks because those slides have that stuff. And we can save a little more time for the presentations and the questions. Question period at the end, we have around 15 minutes. Feel free to submit them in chat or through the Hoover app, I think is how you pronounce it. And with that, I think everyone should be good to go. And I'm just going to pass it over to Claire, and Claire can hop in with her presentation.
All right, just give me 1 second here. So hi, my name is Clair Kronk, and today I'm going to be presenting on gender edge cases in healthcare. So I do have a few content warnings. The presentation will last about 15 minutes. So if you would like to leave, if any of these things are troubling for you, and come back in 15 minutes, that's totally fine. So I'll leave this up for a few seconds to allow those people to leave if they so wish. All right. So a little bit about me. I'm a postdoctoral fellow at Yale University's Center for Medical Informatics. My doctoral thesis focused on creating a large controlled vocabulary, focusing on LGBTQIA+ terminology. And in my postdoc, I've been mostly involved in consulting for major medical organizations in regard to their standard terminology systems. So one thing that I start all of my model building with is, of course, and unfortunately, an old statistical quote by a white guy, since ostensibly going over the fact that models are always imperfect due just to the laws of physics. We cannot model a perfect system in a computer, for instance, or a mathematical model. And so you have to take a step back and realize no matter what you do, it's going to be a little wrong. And so with that in mind, I'll move into the presentation as a whole. We're going to talk a little bit about queer linguistics, about how language matters in healthcare and how sometimes it doesn't. Presenting one base model I worked on with several other trans people recently in an American context, a US American context specifically, that could potentially be expanded in international contexts, and some of the edge or use cases that we discuss fairly commonly in standardized healthcare meetings. So first and foremost, I know there's a lot of back and forth on ContraPoints, but I have to say, I think she did a wonderful job of summarizing how linguistic forms are co-opted by groups based on oppressive and discriminatory forces. So it is not uncommon to see something like this, wherein people of color have particular protective terminologies to signal, if things are wrong versus an outgroup, and that these then get co-opted until they eventually rise to be general terminology. And so sometimes this system gets involved in what is called by Julia Serrano, the activist language merry-go-round. And what this means is that sometimes we have words that become slurs and then they become reclaimed or they lose that context, and this goes around and around. And so activists are always coming up with new terms that are better than previous terms. What is better is ultimately subjective, and it depends on a number of different factors. But sometimes we even forget that something was a slur. And so like you have sod in a lot of British slang that people ultimately forget was an easy way to tell people to go to hell, which is now lost all connections to the term sodomy, or the term suffragette, which was originally an anti-feminist slur, which is now just synonymous with the movement. So we need to think about things like this, how language changes and evolves when we're creating standards. So the one platform that I put together with a number of other trans people in the US American context was a two-step here for use only in healthcare systems. We decided to go with a gender modality framework. That is, we wanted to see if there was an incongruence between two items in a two-step. These then are encoded using US CDI and HL7 data points or data items. HL7 being the health level 7 and US CDI being the United States Common Data Interchange format. These are basically standards that say, if you're talking from one machine to another machine, how do we translate between those two machines? So we don't even have just human languages to worry about, we have computer languages. And so these one-step systems can work in particular scenarios, but you have to consider how they relate to each other in a temporal context. So for instance, transgender has changed a lot in its meaning over time, and it's not exactly clear what groups that contains or does not contain based on age groups. A lot of people ask me why intersex isn't listed either as a gender identity or assigned gender at birth in our base core data set. And the reason is because I am not an intersex person, nor do I claim to speak for intersex people. And that the Interact data collection guide and question design recommends a third question that's more specific in medical contexts. And so I've done my best to reflect that in my work. So on to use cases. So this is probably one of the most traumatizing use cases. I'm sorry to front load this, but oftentimes we don't get like entries which are voluntary to medical care. As medical care becomes more expensive, a lot of people avoid prophylactic care. A lot of people end up in care systems because of accidents, because of things like what is very common in the US and several other countries being prescription opioid poisonings, which were alone responsible for 30,000 deaths in the United States last year. And so oftentimes people are not conscious. And so these typical question platforms aren't possible. We don't know if family might be there, if family is affirming or not. It can be very unclear and difficult to navigate. You can't always rely on documents that an individual might have with them. Because they might not be updated, for instance. And so one thing we have an issue with are what are called patient identification algorithms. And what these are there ways to potentially use similarity indexes to say whether or not a patient has already entered that electronic health record at any point. And so whether or not we can find that means that we might get information that might take upwards of 24 hours to get via laboratory tests. And because such poisonings are usually repeat encounters, and we might even, have some idea of what a prescription might be, but the bottle might be gone, we can more easily potentially find who is this person, what might they be going through? And in a lot of cases, this can mean the difference between somebody dying alone or dying with a relative family member or friend present. And so that's something that's a major concern in emergency settings. To take a step back from that, This was a more interesting use case, less traumatizing at the least, that was brought to me at one point by people at the British Museum, where they wanted to ask about workflows for gender identity and assigned gender at birth with mummies. So obviously, you can't typically see the individual, especially if there's a full sarcophagus. But what people often don't realize is that doctors have to legally ask particular questions to avoid liability or stay in line with hospital standards. And so, for instance, one of the most common ones is, are you pregnant? Now, a lot of times somebody will say, I'm a lesbian, I'm asexual, I don't engage in that. But we typically have to ask that for liability reasons regardless, because it could actually deduct how doctors are kept within the medical system if there's an audit. If a patient was pregnant and we didn't catch it and a drug might potentially harm the individual, the fetus, or both, we have to keep that in mind. So on to the third use case. A lot of times we end up in difficult situations where we might not have a full body. It's not uncommon, for instance, to have a severed finger or a severed arm end up in one ER, and for the rest of the person to end up in a different ER. And so matching those parts as quickly as possible is the best way to ensure that they get reattached. And of course, that's extremely time sensitive. However, in some circumstances, we're not as lucky and we only have bone evidence. And so we rely on individual organizations like the Transdo Task Force, that's the TDTF, to tell us how should we go about these sexing mechanisms, which are heavily flawed, but can often mean the difference between knowing whether your family member has died and them potentially not being identified for years. On that note, we do often have questions about uncontacted or minimally contacted peoples. The Sentinelese, for instance, on North Sentinel Island in the Bay of Bengal, are a people who have responded to colonialism in a very appropriate way, which was aggressively, and they have not been colonized since. However, in the wake of COVID, there are concerns that uncontacted peoples could become infected, and without natural immune system buildups, it could wipe out the entire people. And so, especially in Brazil right now, there are major efforts to vaccinate native populations and indigenous populations, but we have issues if there are no interpreters, if there are no identification documents. What is a person's assigned gender at birth, for instance, if they've never been assigned one or never have been in medical or legal systems? Then everything breaks. And so we have to keep these sort of things in mind. Use case 5 goes into how plastic assigned gender at birth is as a datum. So it's not uncommon for intersex individuals to have more than one assigned gender at birth. And so when you're designing these mechanisms, you need to keep in mind, what do I do in these situations where the medical record might be incomplete or might have conflicting information? And finally, use case 6 is one that's a popular topic right now, cardiovascular health, especially among trans people. The difference between social and biological factors in that sense. Of course, these systems, if you've ever heard of Yentl syndrome, showcasing the difference in heart attacks symptoms. These are obviously cisnormative. They're not designed with trans people in mind. And it can be possible that one marker for heart attacks, for myocardial infarct, troponin 1, it is usually linked to assigned gender at birth, or correlated rather. Obviously, assigned gender at birth in and of itself doesn't mean it's here, but most of the time it does. So if you add options like do not disclose, and a patient cannot respond or does not want to, and your misdiagnosis may or may not result in death, that can be something to keep in mind. Here's a list of very few markers that are used commonly in healthcare settings and how they can potentially lead to misdiagnostics. One of the most important ones, other than troponin, is urinary creatinine on the bottom. And that can affect pretty much every 24-hour urine investigation, which are very commonly done in hospitals. Often, for instance, for STI usage, or sorry, STI infection, or for substance use. So in conclusion, we need to think in an operationally efficient manner that takes into account the system as it is rather than as it perfectly could be. There are more than 2 billion medical devices worldwide that need to be interoperable. And we have over 200 world governments with different laws that have to be working in tandem with their health centers. So we need to think very clearly when we do these things on an international scale. And I can see that I'm running out of time here, and so I don't want to cut too much into others. So I'll stop there, but thank you all so much for your time.
Alrighty, Zach, do you want to take it away now?
Absolutely, thank you so much. And thanks to everyone for being here today for this important topic. There we go. I think I've got my slides going right. So I just want to speak to you, and I've got my timer on. I want to speak with you about ethics in the context of healthcare research with trans and non-binary people and share some examples with you. So first, I'm going to discuss calls for accountability, some current initiatives, highlight a few ethical challenges, and then hopefully get to recommendations, although really need some assistance with those recommendations. And so if this is something that interests you, please do reach out to me, because I would love it if we could have more of a community dialogue about the types of recommendations that we want to be putting forward to researchers and practitioners in this area. So in terms of calls for accountability, it's pretty exciting to see that there have been calls for greater accountability from researchers. We know that research with our communities is on the rise, but at the same time, some tensions are becoming more evident. So we have questions about, for example, who has the right to conduct research with trans and non-binary people? What is the extent of community collaboration or consultation that is that should be prioritized? How to protect participant confidentiality, and how to represent our communities in research findings and publications in a way that's really respectful. So some of the things that have come out are some statements, say, from EPATH and WPATH in terms of wording for abstracts and presentations. And then with the CPATH Research Ethics Committee, I was involved in an initiative where we tried to develop some ethical guidelines for research and researchers. And that was done through a series of consultations, both at conferences and online. So there have started to be some guidelines and statements and some publications in this area. But as you're probably well aware, the field and our lives are rapidly evolving, and it can be difficult to figure out how best to represent this information in ways that's really respectful. So the results that I'm presenting to you here, or the information here, is part of a larger project that I was a part of, where we created an evidence map of trans and non-binary research. And it's a little bit older now because the studies were from when I think back now, the studies were from 2010 to 2014, and there's such a large volume, but it begins to give you a sense also of some of the challenges. So when we did the evidence map, we're basically studying researchers, what they do, who they choose to study from trans and non-binary communities, and what type of methods they use. So we're sort of turning the magnifying glass back on them, or the microscope back on researchers. And we also wanted to look at this from an ethical perspective. So we incorporate 3 primary ethical principles, and these are at the bottom of the slide: respect for persons, concern for welfare, and justice. So I'm just going to go through those 3 areas and share some examples with you, because I think this is one way that we can sort of talk back to medical and clinical communities and research communities by saying there are some ethical challenges with what's currently happening, and ethics is also sort of potentially a good leverage point, because in that way we're speaking a common language across medical and healthcare ethics. And so when we think about respect for persons and the research that I looked at in the evidence map, there were definitely a number of challenges, including this idea of centering a cisnormative worldview. So this probably will not surprise many of you here, but this sort of assumes that people will identify with the sex they were assigned at birth, and that any variations are exceptional, unexpected, and unusual and or problematic. And that in designing research, if you came to it with this cis view, then you would think, okay, well, sex is established at birth, it's linked to gender identity, and it doesn't change. So if you thought that, you would design your research and your research questions in a certain way. And so we're obviously pushing back against that to say, whoa, no, your questions are not properly representing the full diversity of human experience. So this is one trouble, is centering cisnormativity. We also see, again, it won't surprise you, but this reinforcement of gender binaries. So there are some clues that researchers and clinicians will give us that they have this view about sort of the prioritization of a gender binary. So they might say, refer to opposite sexes, or use language like both males and females, as if there's no other genders. And they also will sometimes conflate binarism and cisnormativity. So in that way, you might read papers or see surveys where they will assume either that all trans people are non-binary, or that all non-binary people are trans. And so this is, when we study the questions they ask us, then it becomes clear what their underlying thinking is. So that can be very confusing for trans people when we get to the questions on the surveys and we're thinking, well, that doesn't make sense. I don't know what to pick from this list of questions, say, on a survey. And so these are just some, I was going to say some simple examples, but these are some basic examples that just will give you one indication of our challenges. So it might say, and you've probably seen these on surveys yourselves, what's your gender? And so you're asked to select one of man, woman, transgender. So you might be sitting there going, well, do I pick transgender? Then I'm going to be counted as transgender, but I won't be counted as anything else. Why can't I pick more than one? What if the option that I want is not on this list and there's no kind of fill in the blanks or other? We also have, that question's kind of evolved now, I think, and we more typically might see, what is your gender, man, woman, non-binary. And so, again, this can be very challenging for us to answer and to figure out, well, okay, maybe I'm not non-binary, but I do want to be counted as visibly not cis. So what am I supposed to pick from this list? So it leaves us with these difficult moments. And it also means that later, when the results are analyzed and written up, that we will not necessarily be seen or counted. So to move into a few more layers of the challenges, when people write up their papers and their results, there are 2 general ways that they can use non-specific acronyms. And I just put LGBT because sometimes you will have more inclusive acronyms, sometimes not. Sometimes they will use a trans-inclusive acronym, say in the title. So it might be like smoking in LGBTQ plus populations. But then when you actually look into the results section, you will find that there are no trans people. So then you're sort of asking, well, why did they bother putting one T there because now we think it's there. So we go and we look at the paper, but it's not. The other thing that happens is that sometimes people don't mention trans people anywhere in the title or the abstract, but then you actually look at, say, the table of sample demographics and you see that there were trans people included. So this is a troubling on a number of levels, not least of which, as we attempt to do things like systematic reviews or locate research about our communities, the more we have to look into the paper to try to find it, the less likely we are to locate the information. A couple of other things that happen around this collapsing of gender and sexual identity is that the researchers will group all trans and non-binary people together. So you saw from the previous question about, are you man, woman, transgender? If you're only allowed to check one, that means that all trans and potentially non-binary people will just be reported under one label. So this is a challenge. This also can occur, and I'm hoping is becoming less common, but they will ask just a gender question and it'll just say, what is your gender? And then it might say male and female. I'm not saying that's the right thing to do. And then it will say, okay, here's the sexual identity question. And they'll say lesbian, gay, bi, trans, queer, other. And so then again, this is the collapsing, right? Because you're like, wait, but those are not all sexual identities. So we have an example here. This is from, and I don't mean to highlight this one study, it's just one example where they said to assess gender and sexual identity, we asked each participant to choose the single term that he or she felt best described him or herself from the following list of options. So this is also one of those clues to you that the person probably thinks that, gender is a binary. So this is just their language that they used in this survey, and just to give you a sense of what happens. So I'm going to just highlight some of the other areas quickly for you, and these slides will be available online. But some of the other issues are lack of emphasis on informed consent. The researchers don't necessarily make it clear whether we have given explicit consent. Sometimes they'll say things like, we enrolled consecutive patients from blank blank gender identity clinic. So it's not clear if people have explicitly agreed to be part of a research study. There are also case examples shared in research papers without clear anonymization of photographs or documented consent. I've even seen some where they've thanked the non-trans people for letting them have their pictures in the paper, but they did not thank the trans and non-binary people. So there's a lot of challenges about informed consent. I'm going to move forward quickly now and just say there are some other areas. So we have respect for persons, we have concern for welfare. This tends to cover things like misgendering, misuse of trans and non-binary terminology, for example, using like transgendered or transgendering, or just kind of using the language incorrectly. And the other things that happen is that the researchers can use data that is about the person's sex assigned at birth. So they will put them into the groupings with other people from sex assigned at birth rather than going with our gender identities. So to me, this is also a highly disrespectful practice. And as you read the papers, you also see sometimes very disrespectful language that belittles or further stigmatizes us in terms of surgical outcomes or a body image. Unfortunately, there are many examples of, as I mentioned here, to misgendering. The last piece is about justice and just considering what research is really important to our communities. And is that where the money is being put? Is that where the effort is being put? Who's making decisions about what research is done and what data is collected? And how is this then being reported? So those are really some of the key areas, bringing an ethical lens to the idea of healthcare research. So I've tried to start coming up with some recommendations, and as I was looking at them, I realized, oh, these are much tamer than perhaps we should be. So I was like, oh, let's adopt an approach that centers self-determination and that really centers trans and non-binary people. And let's conduct research that is actually relevant to our communities. But some of it gets into these really almost like simple things like, please report data using accurate acronyms, be more specific, be clear about how data will be used with research participants, and use language and pronouns that accurately reflect our gender identities and that is more respectful. So those are just a few, but as I said, if this interests you, I would love to connect with some other folks to come up with some clearer recommendations specifically related to research practices and the reporting of research in publications. So my information is there. I'm at the School of Social Work at McGill, and I've included some of the references that are relevant to this work. Thanks so much. I'll stop sharing now.
Alrighty, great. And then Laurel, take it off.
All right, so if I have any difficulties with my mic or anything, I encourage my panelists to just interrupt me and I will try to resolve it quickly. So I am going to be speaking in counterpart to the research side of best practices, more assessing where we are clinically. So I'll be speaking on collecting and documenting GSSO data from the classroom to the clinic. I do want to give some content warnings. I will be discussing broadly medical mistreatment, transmissia, cis normativity, which is rampant in healthcare and medical settings, as well as I will be briefly discussing body parts and genitalia. And so if at any point any of these themes or elements make someone uncomfortable, I support your safety and well-being and am totally understanding of the need to leave momentarily longer and so forth. So a brief overview of what I plan on talking about today. I will be giving an introduction to me as well as the clinical significance of accurate and thoughtful GSSO data collection. I will be giving an educational overview both broadly through the literature as well as in my own experience. And then I'm going to give a brief walkthrough of EPIC, which is an EHR or electronic health records software that is especially common and highlights some of our current practices and limitations. So this is me in a place appropriately called Canyonlands with a hat that I was really excited about. I'm an MD PhD student, as well as a person who has been trans in clinical spaces. So I take it both on the side of a person being educated and practicing medicine, and also someone who has experienced the shortcomings in a variety of ways. I am one half of an MD. I have an advanced certificate in pediatric care because adolescent care is my intended field, particularly with reference to queer youth. And I am beginning a PhD in computational genomics. So I am very passionate about accuracy of data and data sets. I also want to comment that I am a white American, and that has a predominant impact in both my experiences and my perspective and some of the limitations of what I can speak on and what I can't. And so I want to acknowledge those positionalities and comment that I will be mainly focusing on the American US system in this talk. So why is accurately documenting gender, sex, sexuality important in a clinical context? Well, there's the good, the things that we want. We want patients to be gendered correctly. We want patients to have language that reflects them in their appointment and in sensitive exams. I wanted to give a shout out to Bex McFife's Your Patients Might Look Like Me, FYI, representing trans in gynecological exam medical training. That was in the Reproductive Health, Justice, and Rights for a wonderful discussion of some of the sensitive exams where language that is patient-directed is especially important, and accurately documenting aspects of your patient's identity is necessary for those to take place. Also, in reference to Zach's presentation, we want thorough and accurate data for analysis so that we can meet the specific needs of various communities. And I believe the documentation is integral to that process. We also want to avoid the bad. We don't want to require provider education by patient, which is something we know to be incredibly common with trans individuals in medical spaces. We don't want to do such a bad job that trans people avoid healthcare. We know that that happens and happens frequently. There are also a lot of possible pitfalls with complex medical needs that are treated by large healthcare teams that communicate largely through these electronic health records, where if we have inaccurate terms or identities, those are going to get shared to a team of individuals who are then all going to do a bad job. The ugly, as Claire mentioned, there are specific health needs that are determined by current physiological status, perhaps someone's hormone or predominant hormone, as mentioned by someone in a question that's already been asked, that is an excellent point, may differ from their legal sex that is recorded, and we may not have appropriate clinical intervention. We also may not be screening for elements, for body parts that are not known by the provider, and we may miss early detection of cancers that lead to worse outcomes. One of the things that is most frustrating to me is also insurance can be really difficult based on what legal sex is recorded, and you may need a clinical screening that is not covered by insurance because of the legal sex that is documented, and paying out of pocket for something like that based on a technicality is not something that I think is reasonable. And then everything else, these are just salient parts of our identity that are going to come up and should be respected, affirmed, and so forth. Our healthcare setting, particularly in my experience in the US, is cisnormative, heteronormative, a white supremacist institution, and the least that we can try to do is to be accurate. And so what do we know about where we currently stand with gender and trans-related education for health professionals? I am sure I am going to shock all of you when I say we're doing a bad job, at least in the US. I am on the GLMA Health Professionals in Training Curriculum Reform Committee, which is a mouthful, and I apologize for it. Where basically we are working on setting curricular standards in the US for a variety of health professionals, because according to data, they do not feel comfortable or prepared to take care of queer patients, while at the same time recognizing the relevance and need for trans-specific education, with the exception of dental students, which is something to unpack for another day. In terms of US, MD, and DO medical schools, there is a median time of 5 hours of LGBT curriculum, and a third of medical programs had 0 clinical hours committed to LGBT care, which means that all education was preclinical and thus more in theory as opposed to practice. This is a pretty low number of hours, but perhaps I'm biased. We do know that when we educate well, we do a lot of good. We know that specific curricular interventions for LGBT and trans-specific communities both reduce provider bias and drastically increase preparedness. But in terms of where we are now, if we are just going based on our documentation of gender, sex, sexual orientation, we have in a 2019 survey of 1.5 million Epic electronic healthcare records, only 45.9% had the full fields collected in patient files of legal sex, sex assigned at birth, and gender identity. And we can discuss the implications of those specific fields. But the reality is, as I will talk more on later, the current tools are incredibly underutilized, which indicates that our providers are not prepared and or willing to use them. So what has my education been like? I as I mentioned, I'm half an MD. I've completed all of my preclinical training and taken my first boards exam. And even as my first day in my medical program, which I actually think pretty highly of, I had to individually petition for better and more comprehensive trans education. So I'm going to use some slides that were specifically from my education. Please do not reproduce, as I did not create them, and please do not get me in trouble. So we have these LGBTQ terms that were presented to us, and Zack has touched on how there's a lot missing already in terms of specificity of acronym. These are limited definitions and do not cover theoretically what you would need to know for a clinic prepared for all types of individuals. And then when we get to how we were specifically told to document information, we're getting into more controversial aspects like preferred name, limitations of pronouns with exclusion of neopronouns. And then I had to raise my hand in front of 200 of my classmates to articulate that if I was asked the question, is your partner male, female, or transgendered, I would leave. And that was someone who was paid to educate me and someone that I had tuition money go towards to be educated in that regard. So there are limitations in theory, to be sure, across the US. And then in terms of practice, in terms of actual clinical interaction with patients, I found that my institution was well-meaning and open to feedback, but we were cis-led, very one-size-fits-all, and there were a variety of stereotypes. Our trans healthcare, clinically speaking, was associated more so with sexually transmitted infections as opposed to the wide variety of healthcare needs that a trans person may experience. I also want to bring up that when I first went into our clinical curriculum, we currently already had the practice of asking, what is your name? Is that what you like to be called, as a method of assessing someone's lived name or used name. And the year after I joined my medical school and tried to incorporate pronoun utilization, the solution was discovered and implemented to use, do you go by Mr., Mrs., or something else, as opposed to directly asking pronouns as a way of assessing gender. But I can tell you this is often reduced to Mr., Mrs., and Miss. And yeah, I have concerns. So switching gears to the real world, I do want to say that in the US, there is a current ruling of the past 5 years or so in which there must be a sex orientation gender identity option in electronic health care records as established by the Center for Medicare and Medicaid Services. Epic Systems is the leading electronic healthcare record in the US and elsewhere. It has 31% of the American market share and more than 250 million patient records, which is a large amount of people. However, as of a 2017 statement by an Epic employee, only 10 to 20% of customers had switched to utilize the optional feature, with maybe another 20% expressing interest of eventually doing so. So to be a little bit more explicit about this, in the US, electronic health records and electronic medical records must have an option for recording this data, but providers are not required to utilize it, and as a result, frequently do not. And even within that system, I know I'm running out of time, but I want to give a feel for what they have. And so we have legal sex, which is often variable and dependent on state to federal, based on different documents, gender identity, sex assigned at birth, and sexual orientation. This was taken from the handbook, which was last updated in January of 2021. There is also a 2018 Epic upgrade in which they began switching from SOGI, or sexual orientation and gender identity, to SGN, or sex gender names, and asking preferred name and preferred pronouns, which I have thoughts about, to say the least, and would love to discuss later on. That the utilization of the word preferred is establishing a dichotomy with legal name, which has its own shortcomings, and that the legal sex must be taken from state-issued identification, but various documents will have potentially different legal sexes, and therefore is not going to be comprehensive potentially. There's also advice that was given with this update on how to collect preferred names and pronouns, such as, is there another name that you like to be called, which is, in my opinion, cisnormative in referencing nicknames as opposed to a person's actual name, and does not necessarily establish trust with a trans patient. And then this almost disclaimer that they recommend with what pronouns do you use? We ask to be more inclusive for all patients. There's data that a lot of providers are reluctant to collect this data with the feelings that they are going to offend patients by asking for pronouns, when one study suggested that only 3% of patients traditionally thought to be upset by this. Older, often rural adults, 3% were upset, and 3% were upset by questions that were not sex and gender related for being too personal. So it's arguably not an issue. I'm going to wrap up quickly. There's an organ inventory SMART form that was implemented by Epic in 2020 to determine what organs and tissues are present versus absent. And that is how it would appear in terms of organ inventory documenting particular organs. And then that just leaves us with several questions in terms of how do we incorporate better curriculum? How do we teach our clinicians? How do we get the benefits and avoid the pitfalls of this data? And how do we guarantee reliable data and utilization with variable programs and people? So thanks so much. Look forward to talking to y'all later.
Yay! Alrighty, now it's my turn to go. Let me just load this up. Share screen, full screen, yeah. Share, present. All right, so everyone can see this all right? Yep, so my name is Roz Queen. I'm here to present on some Canadian context for updating health information standards. I'm going to skip over some parts of my presentations just because they've been covered in other panelists, and that way you don't have to hear me talk about something you already know. So the general overview is context, the 2 grants we've been working on, some future directions, and then 3 big takeaways that I think are the most important parts to take out of this presentation. So for context, this has been mentioned by a bunch of people already, but there's really no differentiation between gender and sex assigned at birth, and this leads to a lot of problematic assumptions. There's no non-binary options or gender expansive options such as two-spirit or intersex. And also data is used in a bunch of different contexts. So like administrative data, like legal sex versus like clinical care stuff, statistics, research, et cetera, et cetera. And there's a lot of emerging standards for GISO data, but there's no real big consensus between all of these, which represent a problem. So just for an example of this is from my working group. So GISO is us, and then we have like Alberta Health Services, Rainbow Health Ontario, Transcare BC, and then federal level stuff like CIHI, Stats Canada, and then like government stuff. And you see, there's not a lot of ones that share stuff in common, which is to say there's not a lot of consensus. And some of these are what I would call aesthetic differences, such as like using female instead of woman or using male instead of man. But some of them are more significant, such as, you know, some things have non-binary genders, some do not. Some have a bunch of non-binary genders under the umbrella of general non-binariness, but some of them do not and only have non-binary as like a catch-all term, which is definitely not great. Oh, thank you, yes. GISO means gender, sex, and sexual orientation. Sorry about that. Acronyms are not great. All right, so moving on to the planning grant. This was done in 2020 with the Canadian Institute of Health Information. Canadian Institute of Health Research. So kind of the work that was involved in this, we did an environmental scan, an ontology paper, 2 rapid reviews, one of peer review resources and one of grade literature resources. We had a monthly meeting of Canada Health Infoway. Canada Health Infoway is a pan-Canadian organization that was set up to try to implement electronic health records across Canada. They have largely failed that goal, but they're still going and the work is still continuing and stuff like that. So we had presentations by leading organizations in this field, such as Stats Canada, Fenway Health, Alberta Health Services, Transcare. And then we also had monthly meetings with stakeholders. So this was to discuss different aspects of implementation of standards. So like policy, practice, research, implementation, obviously. And that was just a place for all these different people to come together, such as community members, clinicians, technical folks, et cetera, et cetera. The main output was an action plan, a proposed action plan to modernize GISO information practices in digital health systems. And then we also had a couple of publications and an infographic just to explain the action plan in a more digestible way. So moving on to this year, we've been doing a REACH KT. KT is knowledge translation, and this is funded by the Michael Smith Foundation, which is a BC health research one. BC is British Columbia on the west coast of Canada, just for context. So our three main areas of focus was sharing our prior feedback, addressing the needs of patients through improved GISO documentation, and then creating knowledge translation tool for different healthcare contexts. So that can be stuff like implementation guides or like local extensions that break down stuff into different stuff, translation into other languages such as French or First Nation languages. And so far the work has been somewhat similar to the planning grant last year, but we're still having meetings. They're called special topic meetings. So we had one on terminology. We have still the monthly presentations by leading experts, such as Clair, who did our presentation 2 months ago now. We created a public facing website that you can check out. Is gisohealth.uvic.ca. I'm the person that built that up. So if you have any complaints or gripes about it, let me know and I'll try and fix that as best as I can. And then we're developing future infographics with different audiences. Okay, so future work. This is what I think is most exciting. It's not the work that it's already done, but where can we go from this? And this is still largely an open question, and it's not going to be decided by me or my team, really. It's going to be decided based off of the work we do this year, how successful our knowledge translation and exchange work is, community feedback. So are we actually meeting the needs of patients? Is this good? Is this bad? Is this going to cause more harm than good or whatnot? Like, you don't want to break healthcare, but you also don't want to harm people. And then capacity and readiness assessments. This is something we have heard from a bunch of different organizations that, like, yes, this is good and we really want to do this, but we might not have the capacity to it, because updating stuff like this can be expensive. It can be time consuming. You need to educate people. The staff has to be like engaged and involved. So this also relates to organizational buy-in. So this is stuff like health authorities being like, yes, we want to implement this and we will do this. Like Alberta Health Services, which is for all of Alberta, they recently introduced a smart form for GISO data. But other stuff like electronic health record vendors like Epic, like Laurel was talking about, like they're businesses at the end of the day, and they're going to respond to business needs and consumer needs. They're not going to update stuff if it's going to lose the money. Like that's just straight up how they function. And then professional bodies such as like the Doctors of BC or like nurses organizations or stuff, because they can put a lot of pressure on health authorities and vendors of like, this is the thing that we want. We need to do this. This is our letter of support, because they hold a lot of power as like they represent all the doctors in BC. And if all the doctors agree to do something, vendors will probably respond and health authorities will probably respond. Okay, 6 minutes. So big blue sky thinking. This is like what I hope will happen. I think this is like the most, if I'm in a perfect world, this is what I hope would happen. So pan-Canadian implementation of gender, sex, and sexual orientation standards, cross-mapping to international standards. So Canada doesn't exist in a vacuum and all work doesn't exist in a vacuum. So we have to have like, mapping basically means like, this term in all standards relates to this term in this other standards, or this term relates to this many other terms. It doesn't always have to be a one-to-one. It can be a one-to-many or many-to-one, just so we can share data and interoperate. Just so education in all healthcare programs, Laura was talking about this, where there's about 5 hours, which is obviously not enough to deal with all of our community and all the different intersections of our community and stuff like that. And then mandatory training for staff while they're actually in the practice of healthcare and stuff like that. Because if you had to take one class 8 years ago about queer stuff and you haven't had to do anything since that, you probably forgot stuff. Like I remember nothing from my first undergrad at all. And just so I give you some tools to meet these goals, there's a lot of online sources that you can take, like Soji Nursing is a really good one. That is free to access. There's also ones about prescribing hormones or different types of sexual health stuff. That hormones aren't sexual health, but as another thing that you can find online. And some of these are accredited, so you can get credits for your continuing education. All right, 3 big takeaways, which is what I really hope you take away from this presentation. Honestly, I do not care if you remember where we got our funding from or what Canada Health Infoway or really what my name is. That doesn't really matter to me. I think these are the most important parts that you should take away. So first, just so in digital health systems, it's not just a technical problem. In my field, health information, people really like to talk about technical problems and how to solve them and how to sort them in databases, but that's not enough. It's not enough just to update the data fields, elements, and structures. You need the training and education, and you need quality and accessibility assessments. For example, it's all well and good if you add gender fluid to a gender field, but if no one knows what that is, it doesn't really do much. It just creates more confusion, if anything. And then also, healthcare is based in interpersonal relationships and communication. At the end of the day, healthcare is largely a conversation between a couple people in a room. And that's why you need stuff like names and pronouns to know how to talk to people. And you need to know how to assess their wants and their needs and what you are able to do. And that's not a technical thing. Technical stuff can help with that. And decision support software can help with that. But at the end of the day, it's interpersonal. And then also, just so is extremely culturally situated, even within Canada, what gender means to different people means a lot of different things, especially in different nations that exist within this land. And then if you go international, like Claire was talking about, translating into other languages, talking to people that might not have these concepts that exist in the Western English frame. The importance of having domain area experts. This is the second most important thing. Oh, well, this is another important thing. I'm not ranking them. So you need direct care workers. You need people like doctors, nurses, social workers, medical office assistants, because those people at the end of the day are the people that are going to be collecting this data and using it. And we need to make sure that it integrates into the workflow and actually serves the practice and clinical care. Because they're super busy. We do not want to add something else that's just a headache for them, and especially in terms of documentation. Technical experts such as people that work in labs doing biological assessments, health informaticians, which is my field, database managers, programmers. All of those people need to be involved to make sure that we can actually build this system and it functions well. Especially because sex and gender variables get tied into a bunch of different stuff in electronic health records, which is something Claire talked about. So we need to make sure that those update well and integrate well and actually run. No one wants code that gives you 50 error messages. And then we need the community. Obviously, we need the community. And a lot of these fields, I'm not trying to say that you have to be one of them. I'm technically a technical expert, and I'm definitely a 2S LGBTQI community member. And you need to make sure that we're actually meeting the needs of community, both through clinical care and through research and through statistical analysis and through all the things that we need from healthcare and systems more in general. And all of these are important parts of the puzzle that need to be fit together. And finally, the need for use cases and small-scale implementations. This is something we have heard repeatedly throughout this progress of hey, this is all well and good that we have this, but how do you have to actually implement it? How does this work for my organization? And it needs to be grounded in real-world workflows. It needs to be content and sending specific guidance, such as the health you get in an emergency room is going to be very different than the health you get in a sexual health clinic, and they have different data needs. And then a successful agile approach. So we need to build on momentum and incorporate feedback. And agile basically means it's an approach to implementation and design of you don't just do 1, 2, 3, 4, 5, and you're done. That's it. You do 1, 2, 3, and then you hop back to 1, and then you do 1, 2, and then you're actually, we need to go to 4, and then you go to 1. It's this really fluid kind of revolving circle that incorporates a lot of feedback loop. And successive means like we do it in one setting and hopefully it goes really, really well. And then we can build on that, being like, hey, we did it in this clinic, can we expand out? Or if you're doing it in a hospital, you do it in one department, then you expand out to other departments, and then you go between hospitals. And then you maybe do like just island health, like the Vancouver Island Health, just to see if we can get it all done on the island. And then do we move to the mainland? Do we move across provinces? Building, building, building. We can't just go from 0 to 100. You need to like ease into it, like good sex. All right, thank you so much for your attention. If you have any questions, please send them to me. You can check out Canada Health Infoway. If you type in like Infoway, sex and gender, it should come up. You can check out the website. And I just have to give a big shout out to SlidesGo, which is what the template of these slides are, and a bunch of other panelists used it as well. Thank you so much for making me look like a professional who's good at art, because I am neither of those things. All right, and that would be it for me. We're going to transition into the question and answer period. I know we have seen some questions popping up throughout the session, and some of them have been like typed up as an answer. But I want to draw attention to one that's about, for clinicians, what's your preferred method of asking partners and about partners and sexual practices when taking a sexual history? As Laurel mentioned, men, women, and transgender is not a helpful way to phrase it. I'll just answer my 2 cents really quickly, and then I'll pass it off to people that have a little more clinical care. I think open-ended questions are ultimately best, especially if you're doing sexual history, which is more of a conversation. So you can be like, what gender are your partners, or how do I refer to your partners? Do you have one partner or multiple partners? And then if you have to get into like more nitty-gritty stuff, you can be like, okay, what parts does your partner have, or what sexual stuff do you engage in? Like, how do you have sex? What like safer sex supplies do you do? Do you do any like kink stuff like a bondage? Because that can have healthcare implementations and stuff like that. So that's just my 2 cents. Keep it open-ended, keep it like casual instead of very like formalized, and don't feel like you have to check off boxes of like, yes, we got this, there's this. Like, what is important to you in this moment, and what is important to your patient in this moment? That's my 2 cents.
I want to comment on that. It's really important that your patients understand what you're asking. And the anecdote I tell often with questions about sexual health is when my partner told their provider that they were not sexually active, and I was like, I'm pretty sure that you are, and they were like, well, it's like it's been a couple weeks, and they were thinking of it in terms of physical activity. If someone was like, oh, are you active? Are you exercising 3 to 5 times a week? And he was like, no, I guess not. And so I think that one of the challenges with all sexual health history taking is that we're asking the same generic questions, and we might have a different assumption than our patient's assumption of those questions. And when we add queer identities that are unfamiliar to cis and straight providers, we're going to miss out on so much more. So for me personally, I'm always thinking, why am I asking this question? What am I actually thinking about with the question? Why do I need this information? Because if it's just for my curiosity, I shouldn't ask it. And then, does my patient understand what I am asking them enough to give an answer that we will both be happy with? So that's my process with sexual histories.
Alrighty. And then another question we had, I'm going to paraphrase because it's a little bit of a lengthy question, and Claire has given like a wonderful response in the Q&A that you can probably read, hopefully. But it's a question about, oh wait, what am I looking for? Oh, I lost it. Beans.
Is it under the answered part, Roz?
Maybe.
Yes, it's in the answered section at the very top.
Nice. Well, Claire, do you just want to take it away and talk about it a little bit? If I can push that onto you.
I can do that. It was a wonderful question, and I should have made this more clear during my presentation. So right now, the way that systems work is there's one sex or gender datum, And as Laurel showed you in EPIC, EPIC has other data, but those are stored in a different section called social history. So they're not actually present in all parts of the EHR. Depending on the install, EPIC is very customizable. So you might have, for instance, a hospital that doesn't communicate social history in various circumstances. So it's very common, for instance, for labs to not take social history. So if you're sending a urine or a blood test to a lab, you should kind of assume that the social history is not going with that data, at least in the United States. Different countries have different regulations of how that's supposed to work. But basically doing a two-step, having an assigned gender at birth and a gender identity is a different institutionalization of the proxy system. That sex or gender variable is just a proxy for hundreds, if not thousands, of underlying variables that are difficult sometimes to measure. And what we're doing is we're getting more accurate with a two-step, but that doesn't mean we're covering everybody. And it will honestly also still be exclusionary. The difference is here is that we're hoping to close a little bit of a gap for eventually getting rid of this proxy system completely. Now, what we should be working and doing is finding out everywhere that this single datum exists and trying to find out what it's actually meaning. Some of these proxy systems were put together more than 50 years ago. And so the original authors of a data set might be dead. And so we don't really necessarily know what they meant. One example of something that's really, really difficult to find a different proxy for is irradiation limits for various organs. This is a huge problem in pediatric cancer if radiotherapy becomes the only option. So we actually do sex typically based on assigned gender at birth, but it's usually based on the radiologist's preference. And that can be different from radiologist to radiologist, wherein you want to make sure that you're penetrating the wall of the organ, but not too deep that you might actually exacerbate the cancer or create new cancers or destroy the organ. And so you can't typically cut somebody open and measure how thick the organ is. And so assigned gender at birth becomes just a better proxy of that. But it's still a broken model. I don't want to sit here and claim that this is going to solve all problems magically. But it will probably take trillions of dollars, a number of intersectional research studies to really find out what these proxies are actually referring to. Some of them are easier than others, and the hormonal ones especially should be easier to move out more quickly. But of course, there are exceptions to everything. And I don't want to claim that it's a perfect system.
Okay, great. I found the question I was looking for. It was in the Hoover app, not in the Zoom one. So yeah, this has already been answered a bit, but I think it's an important point to talk about. So for the two-step gender question, pros and cons of having man and trans man / trans masculine as separate categories. This is a big debate within our community, and I've heard a lot of different stuff from different things. And I think this is not to say that this is the solution, but I think one of the good solutions is select all that apply. Like ideally for me, if I get a gender question, I would select like woman, non-binary, and trans, because those are all big parts of my identity. But we also shouldn't force people to out themselves as trans, especially that can be like really risky, especially if you have seen a lot of the stuff going on in this United States of America, where like that is being classified as, no, people that provide care to them is being classified as like a human rights violation, stuff like that. And we also have to remember that like, you know, being queer in any function is still illegal in a lot of countries around the world. And so being out as anything is really, really dangerous in a lot of different settings, especially different cultural settings and stuff like that. So I think my project, we have always included like, do not disclose, do not want to answer or something like that. And then also an other, where like if someone does not, no, not other, not listed is what we use, because other literally otherizes people. So like not listed or prefer to self-describe or stuff like that. So if someone comes across it and they're like, well, I'm a man, but I think it's important to like say that I am a trans man, they can write it in there. Or to have options of like trans as an option that they can select in addition to man. And that also gives you more rich data to do analysis on and stuff like that, where you can see like, well, how are men faring in this? Because so many studies that I read are like, okay, we're gonna talk about women. And I'm like, okay, you're talking about cis women, or you're talking about like AFAB people that like, that is how you determine who's a woman and who's not. And then you can be like, all right, let's see how like trans people in general are doing with like COPD, which is, I always forget the acronym, but it's something to do with your like respiratory health and stuff like that. So you can actually do analysis on that and not have to use these proxy measures of how to get at that data. So I think Select All is a really good way of making sure people feel represented and included, but also always giving people a way out. So yeah, we have about 3 minutes left. And I think we walked through all the questions in the chat. We had some questions about like providing slides and stuff like that. And that's something we're hopefully gonna figure out after the session. Just keep an eye on the app.
Yes, just chiming in there about providing slides. If I know this isn't quite on topic, but if anybody wants to just email the conference, email conference2021@tpathealth.org, I can put that up for you. I know Hoover is a little janky sometimes, so I'm happy to do that.
Lovely. Thank you so much, Noah. And yeah, AV suggested just like some final thoughts. So if we all want to take a minute and just go over it, and we'll just do order of presentations. Claire, do you want to start off?
Don't let perfection be the enemy of progress. Things are moving slow, but we can do it. It will take time. Be patient with us.
That's hilarious, because I was going to say things are moving so fast. Well, change is moving fast in our communities. So that's the part that's moving fast. And what I would say is I really appreciate the specificity, and I think we should be aware of cis decision makers who select or cherry pick, you know, 1 or 2 trans and non-binary folks who represent themselves, which is fine, but then have end up having a huge impact on these decisions. I think we need to be more organized in terms of the ways we are giving recommendations. Thank you.
I was just going to add that there are power dynamics in medicine that make it difficult for trans people to insist on the care that they deserve. And I think that we should insist on it anyways. And if you need me to make a couple calls and be mean, then just let me know. You have my contact information now.
Oh, that's lovely. Okay, yeah, everyone else on my panel has said such amazing things. I just want to thank the audience for like coming together and engaging on this. I want to thank the presenters. I think this is a really wonderful conference overall, and there's been a lot of good stuff coming out of it. And yeah, I hope that people engage more with this type of stuff. If you have capacity, that would be really great. But yeah, thanks so much. I hope you have a good afternoon, morning, evening, whatever time you're at. And yeah, I love you all. Thank you so much. It's gonna be it. Last thoughts. Bye. That's bye with an I.